Thank you. Management ocular surface before and after cataract surgery. If you'd asked this question in 2000 when I was a postgraduate or immediately when I started my practice, what is this? This is a disease that starts immediately after cataract surgery, lasts for 1 week at least, and then reduces. This is what we used to tell. Just add some lubricating drop if the patient complained of certain things. But then these two studies, if you look at it, opened our eyes. Happened around 2013 to 2017, wherein ASCRS, which is a surgical society, had to give norms for a medical problem. Between 2013 and 2017, that is the time, maybe 2008 to 2013 was the time when we started noticing dry eyes in cataract surgeries. So the surveys revealed that there is too much confusion. They were overwhelmed with the results and they were unaware of the new tools and guidelines. Hence, this surgical society also asked, what do you want? They wanted an algorithmic treatment, meaning something which is idiot proof. Anyone can follow this and do it. Then came the concept of providing this algorithm. Any algorithm should be consensus, evidence-based, reduced chair time, can be incorporated into practice and classified as visually significant or not. Needless to talk about this slide, IOL calculation is affected, has poor post-op quality, and if you're unlucky in a dry eye patients, we end up with this kind of infections. So this particular talk I've classified into all these preoperative, perioperative, postoperative, and what else we have to do. Preoperatively, please look at this. This is the algorithm that was proposed by ASCRS. Non-invasive surgery planning. It can be possibly repeated. Like I said, it's idiot proof. So even your receptionist or the optometrist can do this and still it will be reliable. So before even the patient is taken up for any kind of workup, do this. Do the IOL measurements, do the pentacam or whatever other things you do. Why is that? We don't want the tear film to be affected. Also, while doing this procedure, you can assess the tear film also. That's how it is. Look at the Myers. Teach this to your optometrist to look at the Myers while looking at it. Any small differentiation on the anterior surface, also look at it. The next step, when the patient is waiting outside, give him a questionnaire. What did the ASCRS study say? They supported this modified speed 2 questionnaire. It was a modified speed 2 questionnaire. What I do in my practice is use an OSDI. Give this, ask them to fill so that you can quantitatively evaluate what are the symptoms for this patient. Then look at the patient. Now, two things they proposed. One is osmolarity and number 2 is the inflammatory marker. Practically, this is not possible. You would have heard Dr. Rohit's talk in the screen 3. Maybe someday inflammatory marker surgeries would be possible, but practically doing an osmolarity, I'm slightly away from it. Instead, what I do is look at the tear film height, and then even without a mammographer, you can still look at this meibomian glands with the help of your autorefractor. Then lift, pull, and push the lid. Look at the lid for any changes, say meibomian glands, say blepharitis. Lift the lid again to see any other abnormality. Pull the lid to see whether there is laxity. Push the lid to see what are the secretions. Then you decide whether the person has OSD, ocular surface disorder. No OSD, directly go ahead with the surgery. If there is OSD, you have to see whether it is visually significant or not. How do you decide that? Two things. One is a vision or even your autorefractor or keratometry or your pentacam readings, which changes with every blink, or if there is any such kind of marks on the anterior surface. Second is the staining. So do different ways to find out whether it's visually significant or not. Visually significant, treat this patient and then take up the patient for surgery. Non-visually significant, directly go ahead with the surgery. This is the most important step that you have to follow. The rest of the slides I'll be rushing through right now. Intraoperatively, two things. We know there's a new technology that's being used, surgical temporary ocular discomfort syndrome. That's what it's used for dry eye instead of calling it dry eye, some fancy name. But then if you look at all the mechanisms of dry eye by different surgeries, you would notice the cataract surgery, 4 different methods. That's the significance. That's probably because of damage to the nerves, all other things. So single most thing, if you have to take it, do not touch, do not injure anything what is not required. Example, conjunctiva. Don't push the conjunctiva. Very important. And then place your incisions properly. Use less drops. So this is what I do. repeated drying irrigation. How do you mitigate this? Use viscoelastic on the cornea, on the entire ocular surface, cover it. Less eye drops. What is the dictum I follow here? 2 drops of povidone, 2 drops of anesthesia, no NSAIDs, and preferably without preservative. That we don't get. Avoid phototoxicity, reduce the time taken for surgery. Do not touch any part of the conjunctiva. A point to be noted, flax is going to be the future, but remember, dry eye after flax is relatively more common after than when compared to a normal surgery. So avoid damage. Now what do you do in the post-operative regimen? I have a few studies. Again, I'll rush through this. Group A, B, C, and D will directly go to what they found. Group D, using lubricating drops routinely with your antibiotic, steroid, NSAID, and dilating drops provided much better safety. Patients were satisfied. Schirmer's T-BAT was reduced. Schirmer's was normal and T-BAT was also normal, and only problem was due to frequent usage of drops, patient was not very happy with the fourth thing. Cyclosporine, only when there is proven visually significant dry eye preoperatively, use it. I'm not going into the studies. This is one thing. I was in a period when we first started with dexamethasone, and immediately within 2 to 3 years we had shifted to prednisolone. Noticed all the dry eye after shifting to prednisolone. Probably there's some factor. That's what this study proves. Shifting back to dexamethasone would be better. Use less of NSAIDs. Very new index, ocular surface frailty index, not yet proven, but then what it says is anything takes 9 different factors and says anything in this above 0.33 is supposed to be significant. How they arrived at it, it's a long story, still not practically possible. What do you use in these patients? Again, look at the symptoms. Try to diagnose dry eye properly, use the algorithms. Now the question comes, I'm a clinician, I don't have all these things in my clinic. Simple fluorescein strip, you can still diagnose and evaluate dry eye. That's what the Asia Pacific Dry Eye Society proved. Depending on the stain patterns, you can qualitatively and quantitatively assess the dry eye and accordingly use the treatment. As regards the treatment, commonest, of course, is the lubricating drops, but then dry eye disease syndrome, you know the amount of treatment that we use. So instead of getting into this particular aspect, let me directly concentrate on what is the lubricating drop that we use, otherwise that itself will be an entire day. Whenever we use any kind of medication, we should make sure that this is a multimodality acting medication. Then we can reduce the number of medicines that we give it to the patients. If you look at this particular thing, tear film stabilization, corneal epithelial bedding, osmoprotective activities, increased mucin secretion, reduced inflammation, which is the only thing that comes here. Of course, it is the last one, serum, which is something which comes very close to that. What is marked here? Hyaluronic acid, or a combination of CMC with trehalose if you can, but this combination right now is not available. In between it is available for some time. Hence, the choice of using a multimodality drug, I would like to prefer, if you look at all these things, HA, hyaluronic acid, CMC. Again, hyaluronic acid, CMC. Hyaluronic acid, CMC. But when it comes to agents reducing inflammation, is the higher molecular weight hyaluronic acid. That's the reason I prefer hyaluronic acid in patients with cataract with dry eye. I prefer hyaluronic acid. But remember, some patients can be allergic to this hyaluronic acid also. Thank you for the opportunity. I call upon Dr. Anandraj Nagesh to come and present us. We'll have the discussions later.